Here I am.
Hello, everybody.
Hello.
Hi, welcome in tonight. Glad to have you. Dr. Lee, I think I actually accidentally muted you if you want to unmute yourself. Sorry about that. Hello, everyone. We will get started here in just a quick second. Okay. Well, welcome everyone this evening. It's nice to see some of you. Feel free to share your camera if you would like, but you do not have to. But I would like to welcome you here tonight. Before we get started, I just want to go over just a few little quick items. We'd love to have you share your video if you're comfortable with it. Although this program, is going to be online, we strive to really foster as much connection and identity with others as possible. I know it's hard online, but we'd love to see you if you're willing. And you can show your video by clicking on that video button that you see there at the bottom of your screen. When you hover over that, you should see it. We are recording the session in speaker view. So when we record the session, we'll just record the speakers so your privacy is protected. And at the end of the program, we will stop the recording so that you can feel free to ask any questions that you might have. But we encourage you to engage with others using the chat function. Either say hello or where you're tuning in from. And also use the chat function as well for any questions that you might have that you would like to ask either Dr. Micic or Dr. Lee this evening. Everyone has been muted, but at the end of the program, feel free, if you do want to ask a question aloud, feel free to unmute yourself. But please remember with the questions that we won't be able to actually answer any specific personal.
You're muted. You got muted.
Well, thank you. Did I go mute? Did I go mute for a little bit, or are we
Yeah,
good?
you're
Okay.
good now.
Okay, I'm good. Okay. So let's go ahead and get going. We have quite a nice crowd this evening, but welcome to NOCC's 2024 Online Summer Wellness Symposium, session number 2, Common I can never say this word, gastrointestinal issues during treatment. But I'd like to take a moment to sincerely thank our symposium sponsors who are dedicated to providing this as a learning opportunity, which includes GSK, AstraZeneca, Merck, and Eisai. But my name is Jennifer McClendon, and I am NOCC's Senior Manager of Mission Programming. And this NOCC Online Wellness Symposium, both our summer session, which we're in now, and our fall session, are really intended to provide you with a better understanding of you or your loved one's diagnosis and its side effects so that you can make informed healthcare decisions and have those conversations with your doctor. We also want to, with these sessions, provide you some really great tips on how to cope and manage with side effects, even those including stress and anxiety, talk about self-care strategies, and finally, although, like I said earlier, we are online, the opportunity to connect and engage with your peers. So for this evening, I am very pleased to welcome our experts, Dr. Lee from the University of Chicago Medicine and Dr. Dejan Micic. Did I say that right? Micic? Uh,
Yeah.
Wonderful, from the University of Chicago Medicine. So thank you both so much for being here. So what I'm going to do is go ahead and turn it over to both of you. And again, we are excited to hear this information. Thank you so much for sharing your expertise with us. So I'll turn it over to Dr. Lee.
Thank you guys. Thanks for everyone being here. I really appreciate that everyone's putting where they're from. That's kind of neat. I love it to see that's kind of great. I see some familiar names as well in the chat. So thank everybody for being here. I'm going to share screen, and I'm a GYN oncologist, and so I do surgery and chemotherapy, as many of your GYN oncologists do. And I really am really happy to have Dr. Micic here because of the fact that he is a GI gastroenterologist expert who I know I rely on in terms of consultations. Many of our patients sometimes see, and I'm going to just share screen to kind of go over just a little bit of like just sort of like level setting, a little bit of when and where and how often GI symptoms come up, depending on sort of like what the time point is for ovarian cancer, and just hit on the topic areas. And then Dr. Micic is doing the hard work of actually explaining all of these things. And I will be here to kind of either answer questions in the chat, or, you know, if afterwards we're doing a Q&A as to how this relates to the cancer care and decision making about that as well. So, all right, let me make sure I put this to the right. Hold on one second here. Okay. Let's see. Share screen. And hopefully you can.
Yep, we can see
our
it.
Screen. Okay, excellent. We are both from University of Chicago, so we're celebrating our 50th year of being a cancer center. So we're excited about that. When we think about GI symptoms, obviously, you know, most people who are on this chat, or if you are a caregiver or a patient yourself, prior to diagnosis, many people, not all people, but many people, about, you know, probably about 60 to 70% of patients are going to have these GI symptoms that was sort of the initiating symptom to either seek care or as part of the diagnosis. So things like bloating, feeling full early, decreased appetite, constipation, reflux-like symptoms. Sometimes people have these symptoms going on longer or even over a short time where you've really not taken in as much and you get deconditioned really quickly. I think there's some degree of frustration sometimes where people feel like, hey, you know, I was having GI symptoms and these weren't recognized as ovarian cancer symptoms. So a large part of what we do is also awareness about sort of workup and awareness about to patients as well as providers about, you know, sending somebody for either ultrasound, gynecologic exam, or CT scans, right? So this is, I think, a common symptom where we're really trying to kind of like know that this is there, and we know that this is where many people start. And I think the hard part about this is that when you get when this was your initial symptom, anytime any of these types of symptoms come up again, they both physically and psychologically bring you back to this point of time, which is a very like, you know, very anxiety provoking time naturally. And so that I think is something that I think of when I think of GI symptom management. So post-operatively, obviously, a lot of this is going to be related to the type of surgery that you had. Was it an open surgery, where most of the surgeries we're doing for ovarian cancer are open surgeries? What was your post-operative pain management? Did that, you know, were there any complications related to the surgery? Issues related to needing a bowel resection, you know, whether there was a segment of small intestine or colon or both removed. The amount of bowel resected can affect your bowel movements and some of the symptoms, as well as, which is not a topic for today, but the need for an ileostomy or a colostomy. And then there's this whole issue of like, do you ever get back to normal, or are we just sort of like trying to readjust what your bowels are going to be like, you know, afterwards? And so this is always difficult because we want to kind of pretend that people go back to completely to normal, but after such a big surgery, we know that there are significant differences in how people are feeling. And, you know, this, even preparing this talk made me realize like, hey, you know, we need to really make sure we're being active about thinking about things such as like pelvic floor therapy, diet and nutrition, you know, referrals ahead of time. So then, of course, we're thinking through during the treatment time. So this is where the, you know, the bread and butter of chemotherapy side effects. So many chemotherapies will cause potentially nausea, decreased appetite. Some can cause vomiting. Hopefully we can avoid that with our medication management. Some can cause constipation. There's the development of new food intolerances or preferences, fatigue. There's a lot of anxiety around nutrition. And am I taking in enough? Am I doing the right thing? There's a lot of, I feel like I get a lot of questions about like the right type of food. Like, am I supposed to not eat sugar? Which is not true. You don't need to not eat sugar. And we can talk about that separately. But I think the ideas around this are kind of both physical and have an element of kind of worry associated as well. And then we know that some things can, even the supportive medication can cause a different problems such as constipation and Zofran. So we have to kind of think through like, what are how are we actively managing things during this phase? During surveillance or a maintenance therapy, right? So you may be finishing your initial therapy, or maybe you're on a maintenance, or perhaps you're on something else as a part of a recurrence, but really in this time period where you're not necessarily having active disease, Sometimes it's the chemotherapy side effects are ongoing, right? The PARP inhibitors, which are a great set of drugs that many people are on or have been on, have really known side effects, and we're asking people to take them daily. And so that can be a really huge issue ongoing. The idea of like fear when similar symptoms occur prior to diagnosis can be a really big important part that we may be playing a part in terms of our providers and all of us saying, well, tell us if you feel something different, right? And how do we really gauge, how to report, how to be worried, when should we not be worried? And I think in the background of this during the surveillance time period is a very real and documented fear of recurrence, which is a really, a type of stressor, a type of anxiety that's very specific to patients who have a cancer diagnosis. At times of progression or palliation of symptoms, again, we often think about like concerns regarding nutrition, goals of care. We're not going to talk today about malignant small bowel obstruction and management, but this is important to know that this is something that can happen for patients who have ovarian cancer, and we hope that it doesn't. But we want to kind of like be aware of, what our options are going to be, and this includes medication management as well as GI interventions. So I really wanted to kind of set the stage a little bit just in terms of like talking through like how important we think GI symptoms are throughout different points of care. And then layered onto this is that there are some people who may have ongoing GI issues that happened before, right? There's some people who have irritable bowel or Crohn's disease, or maybe they have diverticulitis or diverticulosis rather. So there are other things that can kind of come up as well that can be layered onto this as well. And that's important to take into consideration. So I am going to stop sharing right now because I want to be able to give Dr. Micic all of the time, and his slides are much more thorough and very informative. And again, thank you so much for presenting today.
Well, thanks to Dr. Lee, thanks to Jennifer and the NOCC for inviting me to give this talk on gastrointestinal symptoms and ovarian cancer. So, the NOCC from last October has a discussion on gastrointestinal symptoms that focuses a little bit more about gastrointestinal obstructions, adhesions, and malignant bowel obstructions. And so I really wanted to kind of take it back and look at just general GI symptoms that are going to happen in the general population, and that can also be exacerbated in the setting of a new diagnosis of ovarian cancer or in individuals that are undergoing therapy, surgery, or ovarian cancer survivors. I'll apologize at the start. I always kind of like to talk a little fast, but
that's okay.
Probably slow it down on a recording. But at the same time, it also then gives us some time for discussions. As an outline today, I have about 30 slides that I want to do about 2 to 3 slides on just what is the prevalence of gastrointestinal symptoms in individuals with a history of ovarian cancer. And then really just I frame this as the most common things that I'll see in my clinic on a daily basis. And so upper gastrointestinal symptoms of bloating and nausea, lower gastrointestinal symptoms of diarrhea and constipation. And we'll see a few little figures here on what I mean when we talk about the difference between upper and lower. Now, as Dr. Lee had highlighted here, individuals in the course of diagnosis of ovarian cancer can be undergoing chemotherapy before or after surgery. There's a bigger effort on cytoreductive surgeries, and that includes actually now even resections of parts of the gastrointestinal tract. We're often having resections of the peritoneum, which is really the lining of the intra-abdominal cavity. And so that can also have an impact on gastrointestinal symptoms. And there's also even a larger focus now on intraperitoneal chemotherapies, and that again can have impacts on symptoms. And so if we look at just 2 real studies on prevalence of symptoms, these are both going to be from Europe. The first one on the left is going to be a 14-country multi-center study of over 1,000 patients, now all 5 years out from a diagnosis of ovarian cancer. Only a quarter are undergoing active chemotherapy or active cancer treatment at this time. And we can see that about a tenth or 11% had some gastrointestinal resection. 15 to 16% are having gastrointestinal symptoms, and that'll go up to a quarter of all patients if you also include just ongoing nausea. So realistically, up to a quarter of individuals, even 5 years out, are having some form of gastrointestinal symptoms. Now, we don't know how many were having gastrointestinal symptoms even before diagnosis, and as Dr. Lee was alluding to, obviously these can be very common in the population. Simply irritable bowel syndrome. Well, I like to say everybody is allowed to have a little bit of that. The second study comes to us from the Netherlands of 230 patients, now all in various stages of disease management, from a new diagnosis to active chemotherapy, having a cytoreductive surgery, in remission, and those in recurrence. The most common gastrointestinal symptoms are going to be appetite loss, which we're going to discuss. That goes along a little bit with nausea, constipation, and then diarrhea. This was worse during chemotherapy and then also after surgery, and then also at the time of recurrence. And that's going to be highlighted a little bit on this table, showing that the most common symptoms of nausea are going to be during chemotherapy and after cytoreductive surgery, but really all of the symptoms are going to be the highest also at the time of recurrence. And this can really be an anxiety-provoking type of a symptom for individuals on really what's going on within the intra-abdominal cavity, intra-abdominal space, and is it related to a cancer recurrence. One of the things that I always like to kind of highlight is really just what is the progression of the symptoms, and how often are they occurring? If I just take a step back and look at my individuals with inflammation in their colon, and they call on a Monday and they say that they had diarrhea, I ask them, well, what did you eat yesterday? Because really I look at kind of consecutive days of symptoms and really how persistent are the symptoms on a day-to-day basis. So I took two slides that I give to our first-year medical students, and this is really kind of what I love about gastroenterology, and really just how fascinating the gastrointestinal tract is. So just to take a step back and just to think about really what's packaged within our abdomen. People will say, how can I have diarrhea when I'm not eating? Well, we take maybe 2 liters of oral intake in, but there's anywhere between 8 and 10 liters. 8 and 10 liters, so 4 to 5 2-liter bottles passing through the gastrointestinal tract on a daily basis. The stomach produces its own fluid. The liver, the pancreas, the small intestine itself actually produces fluid itself. The majority of everything gets absorbed in the small intestine, and we'll see a little bit on the next slide. We have anywhere between 12 and 20 feet of small intestine and 3 feet of large intestine. The small intestine is really, for me, well, that's my bread and butter. That's a fascinating organ for me, but it really does the big job of absorbing all of our nutrients, our macronutrients, so our carbohydrates, our proteins, our fats, really the majority of the water and the electrolytes, and then all the micronutrients, the vitamins, and there's various places that these will get absorbed. The colon has basically less than a 2-liter bottle that enters it, so 1.5 liters enters the colon, and the final concentration of stool happens in the colon, such that really less than a soda can comes out. 8 to 10 liters goes in, less than a soda can comes out. Look at really what the intestines are doing in terms of trying to absorb. Our bodies were designed to absorb everything that really goes in. And so how does it work? Well, it has a really redundant surface area. This is just a microscopic picture of, these are what are called villi, or finger-like projections on the small intestinal surface. And so I like to say that the small intestine is just sausage casing, but it's aligned with these finger-like projections. And each individual cell, which we can't even see on this picture, has over 1,000 what's called microvilli, and that expands the surface area of the small intestine. What I like to tell our medical students is, if you look at the surface area of the small intestine and you were to fillet it open, it's the size of half of a tennis court. Spill a soda can on a tennis court and look at how much absorptive surface area there is and how much redundant surface area there is. Nothing is spilling over the edges and leading to diarrhea. We have very specialized cells within the small intestine that are absorptive cells. They're absorbing at the same time sugar, water, and salt all together, and that's really the basis for drinks such as Gatorade, liquid IV, and Pedialyte. Basically balanced salt solutions, so salt, sugar, and water all in a specific concentration to allow for the best absorption. We'll see it later on in the slides. Overly sugary, concentrated sugars maybe don't get it quite absorbed as well as the more dilute sugars. And there's in general a division of labor. This is just like a small little pictorial, but the majority of things get absorbed in the small intestine. But even there's going to be a compartmentalization. So iron and folate get absorbed proximally. Distally is vitamin B12 and the fat-soluble vitamins. And then we can actually have some calorie salvage within the colon itself. And this all plays a role when we talk about gastrointestinal resections. If we said 1 out of 10 patients had a gastrointestinal resection, well, that can mean a lot of things. That can be the top part of the small intestine, the bottom part of the small intestine, the right or the left side of the colon. And each of these patients will have a difference in symptoms. And so what are the consequences then of intestinal resections? And so really, when we say that there's a lot of surface area here, the resections of the very first part of the small intestine generally are pretty well tolerated. If we take out a piece of that tennis court, well, there's so much more tennis court that's left over to allow for absorption. If we take out the end part of the small intestine, it absorbs a specific breakdown product within the GI tract called bile. And when that bile seeps into the colon, that can lead to diarrhea. So distal small bowel resections can lead to a pretty common diarrhea, but not necessarily malabsorption. Large resections of the small intestine. So if we said that people have anywhere between 12 and 20 feet of small intestine, 3 feet and more, we're going to start losing some nutrients potentially within the stool. And so we have to see how can we alter the diet to make it so that more gets absorbed? So actually carbohydrates will get absorbed better than fats. And then when we talk about surgeries to the colon, actually particularly the left colon and the rectum, it seems almost counterintuitive, but both constipation and diarrhea can happen when we lose the compliance of the rectum. The rectum is really the storage vault of where stool is supposed to sit, allow us to get through a meeting, get through a car ride, but both constipation and diarrhea can happen with low colonic surgeries. So now I'm going to kind of go through the 4 conditions that we're going to discuss today of bloating, of nausea, of diarrhea, and then of constipation. And it's more or less 4 slides per condition to discuss the background. So just really what is some of the nomenclature and prevalence, a description of really kind of how I like to think of it, a basic workup, which is going to be similar for a lot of gastrointestinal conditions, and then the very basics of management. I think there's going to be a lot of terms that are thrown out here over the next couple of slides, such as FODMAP diet, various types of laxatives, and then even actually nerve-acting medicines that can act in the stomach. These are things that people have probably heard in the past, and I want to just really kind of normalize them to say how I like to approach them. Sometimes one thing that I find is that individuals will take something and be overly strict, particularly when it comes to kind of dietary advice in the GI system. So bloating and distension, this is a pretty common occurrence that we'll see in a gastrointestinal clinic. Just when it comes to actually how I think about the wording here, bloating is really a sensation. It's what we feel of increased abdominal pressure or tension, and then distension is actually the visible distension, the visible stretch that we'll see, and that can actually, when measured in studies, be about 3 centimeters of increase or a little over an inch of increase in waist size. This can happen a little bit more commonly in females and males, so up to 5% of females, 2.5% of males, but it can also be very common in other conditions such as irritable bowel syndrome, bacterial overgrowth, constipation, or other causes of altered motility, usually due to surgical resections. It's a really interesting kind of a phenomenon of what causes bloating and distension. It's really not very well described, but there's a group in Barcelona, Spain, that's really done a lot of work on this over the last 10 years. Basically, what they've shown is that some irritation within the gastrointestinal system, so this is either going to be stretch of the small intestine or simple stretch of the colon, which can come from something as simple as constipation and stool in the colon. Rather than having a relaxation of the diaphragm and a contraction of the abdominal muscles, we're having a contraction of the diaphragm, which pushes everything into the abdominal cavity, and relaxation of the abdominal muscles, which leads to the visible distension that people often see along with the symptoms of bloating. And so it's often somewhat difficult to actually kind of manage the visible distension, but what we have to say is, well, what's causing that sensation? And then what's causing the firing of the nerves in the small intestine? And so what we look at is going to be prior intestinal surgeries. If there's been a connection between the small intestine and the colon, there's more likely bacteria that are going to travel up into the small intestine that generally are thought to not supposed to be there. Any kind of medications that slow the bowel or overlaps with constipation are going to lead to stretch of the colon. If there's stretch of the colon, there could be delay throughout the gastrointestinal system, leading to even symptoms of nausea. We're going to look at cross-sectional imaging like CT scans where we're looking for things like constipation, where we're looking for altered anatomy. And it never hurts to really look for other conditions in the gastrointestinal tract, such as even celiac disease, which is an inflammation in the small bowel that happens in 1% of individuals. Really, the workup from a gastrointestinal standpoint is actually pretty similar for most conditions. You look at the stomach, you look at the colon when necessary, and you look at external imaging when it's available. So how do we reduce stretch within the gastrointestinal system? Well, we're going to talk a little bit about a FODMAP diet here in the next slide, and I think a lot of individuals maybe have heard about this. We're going to focus on constipation. Well, we're going to focus on constipation in a couple of slides. And then there's this condition, there's this technique called diaphragmatic breathing, where basically it's a relaxation technique and kind of a retraining of the muscles of the diaphragm and actually of the rib cage muscles, where patients put a hand on their chest and a hand on their abdomen and basically try to do belly breathing. So breathing in and out while moving their abdomen, but not their chest wall. Really what that's focusing on is actually the rib cage muscles, which are the ones that are sometimes actually pushing all the contents into the abdominal cavity. And then we're going to get into really kind of some brain-gut therapies and this idea of what's called central neuromodulators, which are really just nerve-acting medicines. And we're going to talk about that with nausea. These work a lot on the stomach, but also within the small intestine and the colon. And there's various techniques that we'll do with the psychologist within our clinic of hypnosis and behavioral therapies when these symptoms are really impairing somebody's quality of life. Now, sometimes the simplest thing for bloating is going to actually be just to improve constipation and then to try to reduce stretch within the gastrointestinal system. And that's going to be this idea of what's called a FODMAP diet, which has really been popularized for irritable bowel syndrome over at least the last 10 years. The words here of FODMAP, F-O-D-M-A-P, mean fermentable or broken down, oligo, small di-2 monosaccharides, so single sugars, and polyols, which are going to be fake sugars. What happens is we end up taking out a lot of foods in a FODMAP diet that are poorly absorbed in the small intestine. Lactose is going to be the prototypical agent, which is a 2-sugar molecule that does not get broken down with age, particularly after a surgical resection or some sort of insult to the gastrointestinal tract, including chemotherapy. The enzyme that breaks down lactose is no longer present. So that 2-sugar molecule goes to the colon. And I like to say that the bacteria in the colon have a new food source and a party, and they're going to create gas, stretch, and distension. So really anybody with age is not able to absorb lactose. So this is going to be one of the prototypical agents in this diet. What happens is people end up getting very, very strict on the diet or really try to reintroduce certain foods. I try to really say, well, take 2 or 3 things off of the foods that are poorly absorbed and really just try to remove those from your diet. A FODMAP diet can be overly restrictive, and I find many patients coming into my clinic that are overly restrictive on this. I try to focus on the milk products because those are really not necessary and there's alternatives. The fake sugars because there's no need for those. And then pick 2 or 3 foods off of the list. Onions, beans, garlic are pretty typical agents. One thing to focus on, as Dr. Lee mentioned about the sugar, sugar is okay to take in, and sometimes it's the concentrated sugars that are going to be problematic. So an apple juice, which is going to have a lot of fructose in it, is going to travel through the small intestine rather quickly, particularly if you gulp it. But when we make our own Gatorade or oral rehydration solution in clinic, we take 1 part apple juice, 3 parts water, add a teaspoon of salt to it, and now you have diluted forms of apple juice and sip on it over the course of an hour or throughout the day. That's going to be better absorbed than chugging a glass of a concentrated sugar. Now, bloating is focusing a little bit on stretch of the small intestine, a little bit of stretch on the colon. Nausea is going to just be taking it back 1 step, which is going to be focusing on the stomach. So nausea, just like bloating, is a sensation again. So it's that sensation that precedes vomiting, whereas vomiting is now the forceful evacuation of stomach contents. And this is going to actually have a very high prevalence, up to 40% of cancer patients that are either undergoing chemotherapy or receiving pain medications. Now, again, so what do we think about now with nausea? Well, the workup is going to be rather similar. So now are the intestinal surgeries maybe higher up and affecting the stomach, or is it a connection between the stomach and the small intestine? Again, is there going to be constipation or bowel slowing agents? Bowel slowing agents also slow down the flow through the stomach. We have to think about things emptying out of the stomach between 2 and 4 hours after a meal. Well, with pain medications, this can actually be delayed to 8 to 12 hours later. Cross-sectional imaging, we're going to be looking to make sure there's no kind of mass lesions or anything surrounding the stomach or anything impairing the flow out of the stomach. And again, looking more into the stomach as opposed to the colon when we're thinking about nausea. When I think of nausea, and I don't really find that there's much of a role for any kind of dietary modifications. Really, your stomach doesn't really know if it's a piece of steak or a piece of bread that actually entered. It's going to take longer for the steak to break down and get out of your stomach than a piece of bread. But if you're having symptoms within 2 to 3 bites of food, it's not even having a chance to recognize what that food is. We're going to try to improve constipation, remove any kind of offending medications. Antibiotics are very common to also lead to symptoms. But this is going to get into this idea of brain gut therapies, or what I like to term central neuromodulators. What are central neuromodulators? This is really the term that we're supposed to be using in gastroenterology, but they're also known as antidepressants. And this actually takes patients back pretty quick, takes patients back and says, well, wait, why are we using something like this? So the medications that we commonly use are going to be amitriptyline, mirtazapine, and buspirone. And that's because we have more nerves in the gut than we have in the brain. And if we have more nerves in the gut, well, we need therapies that are going to act on those nerves. Well, the therapies that we have are designed as antidepressants. Now, a long time ago, amitriptyline is no longer used as an antidepressant. It's used actually for migraine prophylaxis. Mirtazapine, if anything, is used as a sleep aid these days. And then the buspirone is actually an adjunct therapy that's used for anxiety. I really focus on the first two therapies, and we have to even remember that these actually act on all the various nerve transporters within the gut. And we have to think actually Zofran is a very common anti-nausea medicine. Well, it's a specific serotonin blocker. It also acts on the dopamine receptors, so it blocks the serotonin signal between the top part of the stomach and the brainstem. These other medications actually do something very similarly. They actually relax the top part of the stomach, which is where food goes in first. Food comes into the top part of the stomach, it relaxes. That term is called gastric accommodation. Then it churns in the middle part of the stomach before it exits out of what's called the pylorus. And so one of the medications here, mirtazapine, the way that this is actually judged clinically is actually when you put a balloon in the stomach and then the patient remains awake. Inflate the balloon. How much can you inflate the balloon before the patient feels that stretch, before they start feeling nauseous? Start one of these medicines, now you inflate the balloon and you can inflate it more several weeks later. The other way I like to explain to patients is called the Ensure test. Drink Ensure until you get sick. It's a milky, heavy, doesn't taste that great. Start one of these medicines, repeat the test 6 weeks later. You have a measurable increase in the amount of volume that you can take in, which is why mirtazapine is associated with an average of 6 pounds of weight gain. This is just an example of one of the studies of mirtazapine that shows that as early as 4 weeks later, there's a reduction in the dyspepsia, is really just another term for upper gastrointestinal symptoms. So nausea being one of them. So reduction in symptoms, a reduction in how quickly someone feels full, an increase in body weight, usually by about 6 pounds. And then this is this meal tolerance, which is that there's an immeasurable increase of volume per meal. I often like to ask patients, what's your favorite food? Someone will say pizza. How much can you eat? 1 slice. Start a medicine, 3 slices. And so this is really going to have an impact on the top part of the stomach. So that's going to be the top part of the stomach and the small intestine, but hopefully we covered some common terms of FODMAP diet and some of these nerve-acting medicines that we like to focus on for the stomach. But now we're going to go into the colon and something that everyone's had at least one time in their life of diarrhea or constipation. And so my favorite question in clinic was, what is normal? Well, there's a study from what's called the NHANES database, which is a sampling of the US population. So the 95% bell curve average, we like to say, 3 stools per day to 3 stools per week. Anything in there is going to be considered normal. So having a stool every other day is okay. Missing 2 days in a row can also be okay at times. 3 per day to 3 per week is generally the amount that we're trying to achieve. What is diarrhea? Well, in a clinical setting, it's actually measured by what is the weight of the stool or how much volume comes out. So collecting the stool over a full 24 to 48-hour period. And diarrhea can be sometimes tricky because it can mean that someone's going to the bathroom 4 to 5 times a day. Or once a day, which is considered normal, but very liquid. Or what's most distressing to patients is going to be actually incontinent episodes. And so again, are there intestinal surgeries? Where, how much, and how long ago? Were the surgeries on the rectum? Were they deep in the pelvis, which can actually impair the control of the rectal muscles? Was there even any kind of vaginal childbirth, which can actually impact stool symptoms 40 and 50 years later. Gallbladder surgeries commonly come on with diarrhea. And then when does the stools actually occur, how big and how frequent? So the stools from a colonic source are often going to be smaller in volume, multiple times per day, often in the morning, whereas larger stools and more infrequent are going to be coming from a small bowel source. Now, instead of looking at cross-sectional imaging, we're also going to be looking at things like thyroid function. We're going to be looking at vitamin mineral levels to make sure that those are not depleted, particularly if there's been intestinal resections. But the most important thing is really what is the anatomy. At times, we'll be doing a colonoscopy to grab biopsies of the colon to make sure that there's no inflammation, because various even kind of pain relievers, including the NSAIDs, such as ibuprofen or Aleve, can also lead to an inflammation in the colon. We're often going to grab biopsies of the colon also in the setting of chemotherapy to make sure that there's no adverse drug effects within the colon. How do we manage diarrhea? Well, we can focus on a FODMAP diet, so make sure that there's nothing in the diet that's actually resulting in the diarrhea. And again, not being too strict on that type of a diet. If there's bowel resections of the distal small bowel, there's ways to actually bind up the bile in the colon. And this is often something that's tried, but actually needs to be taken even 2 to 3 times a day. And so we'll often see that patients are not taking it quite appropriately. With larger bowel resections, we're going to have them take bowel slowing agents. This is going to be loperamide or Imodium. Another medication is going to be diphenoxylate or Lomotil. Often patients will say, well, I tried it, said to take it after having 3 stools in a day. I took it and did nothing. But realistically, we actually have patients taking multiple tablets per day, actually preemptively. So breakfast, lunch, and dinner, sometimes even at bedtime, really using anywhere between 10 and 12 tablets in a day of loperamide is not that uncommon with larger bowel resections. And so again, that has to be tailored to the specifics of the surgery. Brain gut therapies, they have sometimes a slight constipating effect, particularly amitriptyline. And so if there's a pain associated with the diarrhea, we will sometimes use that. And what's really not utilized enough is if we're just really lost, we'll measure the stool, take a sampling of it over 24 and 48 hours, and what are the contents? How much fat is in the stool? How much bile is in the stool? What is the water content of the stool? What are the electrolytes in the stool? That can really help explain to try to tailor the therapies for diarrhea. And then we're going to just kind of then flip over into constipation. I think that'll leave us maybe a good 15 minutes for some questions. If the typical stool pattern is now 3 per day to 3 per week, and we're less than 3 per week, well, now we're going to be referred to constipation. And again, this is a little bit easier to question than diarrhea. What is the frequency of the stools? People will also be able to remember that. But the biggest thing to focus on is actually what is the ability to actually pass out the stool, and what is somebody's comfort level of getting the stool out? I like to say, what happens when you enter the toilet? I sit there and I push for 20 minutes and nothing happens. Well, that's really telling us what's happening at the level of the rectum with the muscles. Are they adequately allowing the stool to come out? So again, prior intestinal surgeries, was there anything low in the rectum that was intervened upon? That's going to be called a low anterior resection. How does it come out? How does it feel when it's coming out? And then is there any kind of upper gastrointestinal symptoms because somebody is so backed up? Here, actually taking a simple x-ray of the abdomen is actually pretty nice. If you see stool on the right side of the colon, that tells you that someone often has coexisting constipation. And actually on a CT scan, I often like to look at the rectum. If there's a large amount of stool within the rectum, I know that it's having trouble getting out of the rectum. And we're going to see a few slides on that coming up. Colonoscopy, not always required because we're not really taking biopsies more for diarrhea. But if there is any kind of altered anatomy, it is nice to make sure that everything is open, particularly in the distal colon. So how do we manage it? Well, really, it's the opposite of the FODMAP diet. Well, now we really want all of our fruits and vegetables. We want fiber. Average American diet has about 15 grams of fiber in it, and we should be closer to 30 grams of fiber. When people are taking fiber supplements or fiber pills or fiber gummies, you really have to look on the label how much fiber is actually in there. Taking additional 2 grams of fiber is really not going to do much throughout a day. If there's surgeries low to the rectum, we want to kind of see how is the flow coming out of there. So actually doing dye studies within the rectum and even doing some MRI studies to see how the dye actually comes out. And then the 2 things that I kind of want to focus on today is going to be just the very basics of how we use laxatives. What is an osmotic laxative? What is a stimulant laxative? And then how does stool actually flow out of the rectum? So, laxatives are tricky because there's a whole aisle at the drugstore and at the grocery store on various types of laxatives. And people often try various things without knowing that maybe what they're taking is all going to be the same. So what's termed an osmotic laxative is really something that's trying to retain water in the colon. If anyone's had a colonoscopy, they're often taking a medicine called polyethylene glycol or Miralax. And that's basically just retaining all of the water. Well, you recognize that. Basically, this thing traveled through your colon, it dragged a lot of water in, and all that came out was water. Solid stool never came out. It was all just pure water that came out. So ways to retain water in the colon is going to be as simple as magnesium supplements. The polyethylene glycol, as we mentioned, this is how fiber works. So fiber basically does not get broken down, and it just is a building block, and it retains water. It'll give the stool more form than some of the other agents. But this is also why people take prunes for laxatives. Prunes have been compared to Miralax head to head. They're equivalent, as are kiwis. And then any of the medications that we use, such as lubiprostone, linaclotide, or plecanatide, all do the same thing of just secreting and pushing water into the colon. There's a second form of laxatives called stimulant laxatives, this is going to be senna or senecot. This also comes in a tea. It's actually derived from a tree leaf. There's also what's bisacodyl, and there's a prescription called prucalopride. These actually increase the contractions of the colon. Now, if we think about how the colon works, things take 1 to 2 days to go from the right side of the colon to the left side of the colon. So taking one dose of Miralax this morning is not going to have any impact on my stools really today. I probably won't even notice it until tomorrow. Whereas the stimulant laxatives work 8 to 12 hours later. Stimulant laxatives cause squeezing, so if there's a lot of stool and constipation there, it can actually also cause some discomfort. But taking that in the morning, well, maybe it's going to lead to stools at 5 o'clock in the afternoon when you don't want it. So usually the osmotic laxatives will have somebody take in the daytime, and the stimulant laxatives at bedtime, because there's also an urge to go to the bathroom often in the morning. And so the stimulant laxatives even have more of an effect when taken at night. I usually like to start with stimulant laxative at night. If the stools are overly hard, adding in an osmotic laxative, but the combination, or a little bit of one and a little bit of the other, one in the morning and one in the evening, is a really, really nice combination, particularly for constipation. So often patients will come into clinic, say, I tried this, I tried this, I tried that, but was it ever tried in combination? Was it tried long enough, and was it tried at the right times? Really just fine tuning things. And then the last kind of slides, and I think it's 2 slides here. Yep, is going to be on defecation disorder, which is really the act of how stool comes out. This actually accounts for half of constipation. Really goes unrecognized. It's a paradoxical contraction of the rectal muscles when someone's trying to go to the bathroom. There's 2 sets of rectal muscles, an internal and an external muscle. The external muscle is what you can squeeze when you're in the car, when you have to wait to go to the bathroom. The internal muscle we don't have really conscious control over. What happens is, I like to think of it as really a bad habit of really probably just our Western society, of people holding on to stool for a very long time. When you're in school, you're at work, you don't want to go to the bathroom in public. And then what that leads to is a paradoxical contraction of the internal muscle. The way I describe it to patients is when they go to the bathroom, they're squeezing with their abdominal muscles, just like you're going to squeeze on a toothpaste bottle, but the cap is still on. That internal muscle is not relaxing. It's not allowing the stool to come out. We often see a significant delay in stool evacuation, discomfort. People are trying different positions, squatty potty, knees to the chest, anything to really try to evacuate stool. That's often a sign that there's actually a disorder in how the muscles work. You can throw all the laxatives you want. If those muscles are not relaxing appropriately, we're not going to get the desired effect. Often people also say, even when I have diarrhea or a soft stool, it's very hard for it to get out. And so how is that managed? Well, so first, doing the testing for defecation disorders, not quite that pleasant. We put a balloon in the rectum, and that stimulates a stool, and we have people try to evacuate the balloon in a certain amount of time, and measure the pressures of the rectum with a probe. So I always like to start with a combination of that water retaining osmotic laxative and a stimulant laxative at nighttime. And if there's a failure of basic conventional therapies for a good period of time, then we're going to get into actual testing of the rectal muscles and what they're doing during going to the bathroom. This is where we're going to send somebody to physical therapy, what's called biofeedback therapy, to try to relax that internal muscle, or try to kind of get the sensation of what it's like to relax the internal muscle when going to the bathroom. And so hopefully I've been able to share, and knowing that gastroenterology is a huge focus here. Everything from even bowel obstructions, which was discussed last fall, to the symptoms that we discussed today of bloating, nausea, diarrhea, constipation, to nutrition, which we can even touch a little bit on in the questions. Symptoms can always really be somewhat tricky to manage. What I like to focus on is a proper workup, isolate where is the location of the problem, and obviously understanding in individuals with a history of cancer, there is this anxiety-provoking piece to it. And so that's really where actually having cross-sectional imaging to really rule out a recurrence is sometimes one of the most important things, just to actually make sure that that's been up to date. What that means, though, is also individuals without a recurrence can still have a lot of gastrointestinal symptoms. And we saw even 5 years out, a number of individuals were having symptoms. So we should really, within gastroenterology, we would do a lot of symptom-based management. If things are running through the gastrointestinal tract too quickly or leading to discomfort, we focus on diet. The gastric accommodation, particularly for symptoms that are happening during a meal or within 15 minutes of a meal, or if there's a lot of nausea involved. For diarrhea, we're going to try to actually find the actual cause of the diarrhea. Is it due to a medication, something in the diet, or due to intestinal resection? And then really try to fine tune what leads to diarrhea. Whereas in constipation, we're going to see if laxative therapies help, or if they don't, see how stool is coming out. So a lot of gastroenterology for me is going to be then the fine tuning or the adding of therapies. Patients will often have tried a lot of different things before they come into clinic, and so we really have to just try to get to the root of the problem. Where's the problem located in the gastrointestinal tract, and then put together a management plan. And so hopefully I've been able to discuss 4 very common topics that are going to impact a number of individuals out here. And I'll be happy to take some questions here with Dr. Lee in a few.
Wow, thank you so, so much, both Dr. Lee and Dr. Micic, for this wonderful amount of information. We do have quite a few questions that are coming through, and I think Dr. Lee has got her eyes on some of these as well that she might pick out and
Yeah.
ask. So
Thank you
keep them
so much.
coming.
That was fantastic.
Yeah.
I learned a lot. I took some notes on things that I should think about for my patients as well. So I'm going to go through some of the questions that are here to kind of think through things. I think someone did bring up, these symptoms, even though I don't have a recurrence or I'm in a remission or in a state where there's not any cancer seen, do these symptoms continue and persist? And from my experience, I would say that there are a lot of patients who have these symptoms who don't have any evidence of cancer. And I think you would say the same in terms of people who get referred to see you as well. What do you think in terms of like the side effects of the treatments and the surgeries and all those things are often long lasting and don't necessarily get back to like what things were like, before, I would say.
No, very, very much. We think about diarrhea with a lot of chemotherapies, but I think we've even worked on Avastin, which actually leads to, I think, often higher blood pressure. That leads to sometimes medications for blood pressure. That leads to then constipation, and so actually a lot of medications can then actually lead to constipation. That will even sometimes the blood pressure agents will often lead to long-lasting constipation. The other piece then is going to be, I mean, during this course, did the defecation disorder even develop?
Yeah.
And particularly pelvic floor issues, especially if there's going to be low pelvic surgeries. And so both constipation and diarrhea in particular, I think are going to last well past the diagnosis of ovarian cancer.
I think that, some of the questions that come up one was very specific just about like the side effect of some of these neuromodulator drugs. And so I think that's a good one. I think people are often fearful of it because they're sort of in that class of drugs that was originally designed for antidepressant. I think really emphasizing, I love the fact that it's neuromodulator is the term, because I think sometimes if we don't mention that to our patients get a prescription and then they're like, why do you think that I made this symptom up? You think it's all in my head? Like, and that, I think trying to break that mold. I loved where you said that there's so many nerves in the gut, and that's what we're trying to, so if there's side effects that you'd want to talk about or things that you think about.
Yeah, no, the way I like to think about the neuromodulators is there's actually a big relationship between even kind of sleep and then upper GI symptoms, such that actually melatonin has been studied as a medication for the esophagus. Trazodone, which is a sleep aid, is also used as a medication for the esophagus. The side effects actually are pretty minimal. When we talk about amitriptyline, and as an antidepressant, we're talking about doses of 150 milligrams and higher. And really the study dose in GI just recently was up to 30 milligrams.
Yeah, that's so interesting.
And doses for migraines are 10 milligrams. We start at 10 milligrams. Some people have a little bit of a dry eyes, dry mouth effect, but for the majority of patients, there's really not any kind of side effects there. Sometimes we're looking for that side effect in terms of particularly if individuals have diarrhea. So with a lot of the medications, we're starting very, 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 very low and then slowly going up. And even when we go up, we're only going up to a low dose. And actually, because there's this connection between sleep and upper GI symptoms, I actually really always ask, how is your sleep? And I've had people that say, well, my GI symptoms are no better, but my sleep is so much better, so don't stop the medication. I'm like, oh, okay. But usually it goes hand in hand. And there's actually one large study that says the people that had the most improvement on the medication had an improvement in their sleep. And so side effects are actually going to be minimal, particularly when started low. I think often what happens is these medications get started with very little follow-up. I like to kind of start these medications, see the patients 4 weeks later, making sure that there's no side effects, and then making sure you get them to the right dose. One of the hardest things in GI is you can't just start a medication and then not really follow the effects of it. And a lot of medications, even acid blockers, being over the counter, people say, I tried this 6 months ago, but I don't remember what happened. Really trying it and being objective about its improvement.
No, that's a great question. I think a follow-up discussion or question about that is that, sometimes there are patients who are on antidepressants or anti-anxiety medications already for depression or anxiety, right? And when you're trying to layer on these neuromodulators, do you ever, is there any concerns that you have, or are there other, because I would often think about like, talking to our pharmacist or talking to, what can we do to kind of like balance those things out? Have you ever had situations where you've had to manage that? Because I do think there's a fair amount of our patients who are on some of those other meds for very good indications and are feeling good on them too. So.
And so we're using such low doses that there's often not going to be an overlap. I do try to talk to the other prescriber, whoever's prescribing any kind of medications for anxiety or for depression, just to make sure that there's not any overlap. But I've really almost never gotten any kind of kickback. We're using such low doses. Sometimes I'm going to try to take one of the medications, like the mirtazapine, that has more of an impact on the gut, that's also used for depression, and take away one of the medications, like a sertraline, that doesn't have much of an impact on the gut. So sometimes we'll do a complete flip, which is okay. And medications like the buspirone are actually known as an add-on therapy to other antidepressants.
Yeah, that's a good point.
So it's a lot of going back and forth between the patient and any other prescribers, so that the three of us are in a loop. But it's often very easy to start, even with other medications.
I think some of the other questions, I'll kind of group a couple of them together just to make sure we get them, all is sort of, this kind of this like feeling of like, one of the concerns is, small bowel obstruction. We often think about small bowel obstruction or any type of malignant bowel obstruction being caused by deposits of cancer that are on the surface of the bowel. So we know that that's a common thing that can happen. And in some ways, obviously, our goals of chemo are to try to prevent that from happening and prevent the intestines being an organ that's affected by the cancer, right? But the idea of like, how do we kind of like, think about like fine tuning? I know this isn't we're not talking about small bowel obstructions in general, but thinking about like, how can you kind of like gauge where you are with things, and then perhaps like thinking about like the FODMAP diet, and sometimes this balance between diet and like how much can you control or not. And so I think it's a fine balance, I think. And so I don't know if there's any comments that you'd have about that.
I think we've worked on this kind of stuff together. It can be very tricky. I think folks that have had a bowel obstruction are worried of having another one and almost want to have a stool every day, and to the point that they almost will take laxatives, but then now we're flipping between constipation and diarrhea. And we don't know. We're just flip-flopping. And so particularly one thing that I mentioned with the laxatives and the bowel slowing agents, I try to get on a regular schedule. And so if 3 stools a week is okay, I mean that's still it's okay to be skipping days and even 2 days. I know that there's an anxiety piece to that. Is there a way to prevent a bowel obstruction? There can be tumor deposits on the bowel surface, and that can impact how the intestines move. People often will really reduce the amount of fiber in their diet. They will go more towards a FODMAP diet, which is going to reduce some of the stretch. I think that again, FODMAP principles are important. So don't go drinking a glass of milk, switch it over
Yeah.
to lactose-free milk, lactose-free ice cream, but I don't think of fiber as being quite the issue, because that's not something that really is going to build up until we get into the colon. I really focus more than just on chewing food and being very practical about it. I deal with Crohn's disease a lot, which is going to be narrowings in the intestine, which could be 2-3 millimeters across. And we tell the patients, chew to your food. We don't give them any kind of specific dietary advice as to what foods to take in
Right.
and which ones to avoid, but simply make it so it's a very small particle. Foods are not supposed to exit your stomach until 2 to 3 millimeters across, but we know that shells of beans, the skins of apples, corn husks are not going to be able to make their way through.
Mhm.
So instead of undercooked vegetables, you can still eat vegetables, just cook them thoroughly until they're
Yeah.
mashed with pork. I say, you feed them like you would to a 2-year-old child, so that, you can't even choke on it. You should be the last one done at the dinner table to make sure that food is really broken down, because you're chewing it so.
Such an important point. I don't want to say simple answer, but so true, right? And I don't think I've counseled patients in that way, but that actually is a really, really, really important intervention for sure. I think, Jennifer, you had a good question that I thought I would bring up here, which is like, are there any things that are sort of in complementary therapies or integrative therapies that you think may help with GI issues? Sometimes we think about like, we often think about like, I think you mentioned the neuromodulating things. You wonder about sort of that brain gut connection. I think you mentioned CBT on a slide. If there's anything related to acupuncture or any other complementary therapies that you've heard of.
You mentioned sleep.
Yeah.
Yeah.
Yeah, no. That gets into the role of the whole kind of brain gut connection. Um, this is often this is not fully related to this topic, but I gotta say, in clinic at least once a week, somebody will say, I was in Europe and I had no symptoms, and there's something about the food that's different in Europe, and I
Yes.
say, it's not the food that's different, it's the fact that you are on a beach.
Yeah.
There's a huge connect between stress, GI symptoms,
Such
and
a
really
good
what our
point.
GI psychologists focus on is, if you wake up in the morning expecting the symptoms to be there, they're going to come. And to needing to kind of break that cycle. And so whether that is meeting with a psychologist, acupuncture does have data in the GI world. Exercise has data in irritable bowel syndrome. But really sleep and actually even diaphragmatic breathing. I mean, part of that is
Yeah.
actually the fact that it's simply just a relaxation technique. Yoga we do in inflammatory bowel disease, and so anything to really be able to uh, get the mind off of the symptoms, and for a
Mhm.
prolonged and regular period of time, I
Mhm.
think is important. And that
Right.
really falls into that complementary approach.
That's great. Those are great tips. Thank you.
Yes, those are wonderful. I really appreciate that because I know that we get that question quite a lot. So, I think there was maybe one other that I thought would be good to ask here too. Want to
Oh,
make
yeah.
sure.
Sorry. Did I miss
No,
one?
no, you're okay. You went way back up at the beginning. Let's see here. Someone had asked if they don't like the drinks that were mentioned earlier in the presentation, how can they, get the electrolytes and potassium that they need?
There's honestly, just on Google, there's going to be various recipes. We have a recipe sheet that we will give a lot of patients, that you can make your own basically electrolyte drink out of any kind of juice at home: cranberry, grape, apple juice, tomato juice, broths. Even diluting some of the store-bought juices. So technically Gatorade has too much sugar and not enough salt in it. And so they have different versions that have more salt and less sugar. And so there's pretty much any drink. The typical rule of the one part juice, 3 parts water, and a teaspoon of salt. that's going to often be something that we'll use. But there's lots of different recipes out there that I think even people have used with those kind of various flavoring packets and everything there. Coconut water, yes, not a ton of salt in it. Not a ton. I love it. Not as much salt in it. But yes, it's also another. That's a a very old school type of electrolyte drink.
Wonderful. There was one other one that I thought I might ask too. There was two actually questions that kind of centered around this. For those that may be, post-treatment for quite some time and have been out of treatment for a while, they're asking, will these types of GI symptoms, how long do they last? Do they continue, years and years, or do they get better over time?
Yeah, I mean, I think in a large number of people, the symptoms even sometimes predated the cancer diagnosis. I mean, if we look at just on the big picture, I mean, we're saying kind of, probably 10 to 15% of the population has some form of irritable bowel syndrome, and that can be a spectrum of constipation, of diarrhea, particularly if there's been an intestinal resection, that's going to have an impact going forward, because now we're losing the ability to absorb certain things in certain parts of the intestines. And so now we have to just fine tune a few things to say, okay, well, maybe you need a bile binder every day to slow down the diarrhea. And that could be a very simple solution. So particularly with intestinal resections, I mean, we have to expect that that's going to be a lifelong change.
Yeah. Sure.
I think there was one last question about, it was a little more specific, but just like, when you're using these different agents to kind of like clear your colon, or thinking about these things that you're using to relieve bloating and constipation, is it like, is there a sense of like, how clear should that be? Or, like, how do I know if it's clear enough? And I would almost answer, like, it kind of depends on if you feel okay, right? Like if your symptoms are feeling okay, and you're less bloated, you're less, physically distended, that's what I would use as a gauge. But I don't know if there's other things that you use or tell people.
Yeah, I mean, constipation is less than 3 stools per week,
Yeah.
but even at 3 stools per week, someone's going to have symptoms. And so it's really on titrating the medications to relieve the symptoms. And that, for me, that means taking a little bit of medication every single day, as opposed to taking a medication twice a week when you are constipated.
Yeah.
So being more proactive as opposed to chasing the symptoms. And so in the chat here, we have milk of magnesia that can actually be pretty concentrated magnesium that actually always leads to stools, maybe even a little bit too much. So a quarter of the dose, or even the magnesium tablets, which is going to be less magnesium, taking a little bit every.
Okay. That makes sense.
And so particularly for constipation, we don't need to know how much is left over, let's say, within the stool. Now, with defecation disorder, people aren't getting all the stool out, but that's often kind of, I feel uncomfortable. I feel like not everything came out. And so that's where we'll be testing the rectum itself. If somebody is very, very constipated, sometimes we will give them a bowel prep, just like a colonoscopy to start. But then you have to be on some sort of regimen going forward. I don't do that often anymore. But for me, it's about taking a little something every day.
Yeah.
Thank you so much.
Yes. Thank you, both of you. Before we end the session, are there any parting thoughts or words of wisdom that you want to impart, or anything of that nature?
For me, I think it's really just kind of getting the doctors to work together. I think Dr. Lee and I really work together a lot on patients, and having open communication between the doctors, the patients, all to be on the same page. It's so easy kind of these days, particularly with electronic forms of communication.
Very true.
And for me, with everything GI, kind of what we were just mentioning in the last topic, it's all about kind of proactive management. Often we can flip-flop between symptoms by doing too much of one thing on one day. And so trying to be consistent in how we approach it. Symptoms are going to come on, they're going to be consistent. Our management should also be consistent.
No, I think those are great things. I would say keeping kind of a little bit of track, keeping track a little bit of your symptoms and what you did try, so that when you are going to see either somebody who's a specialist or something like that, they can kind of get a sense of like what actually you did try, what you didn't, being honest about that for yourself too. I think that I think quite honestly, like making sure you're asking also for a potential GI consultation. Obviously, I always think GYN oncologists, we cover a lot of topics, but we're not the experts at all of these things, right? We're experts in the sense of like, we often often like see patients and have patients with those symptoms, and we may have like the very initial thing to try, right? The initial way
True.
of doing things. And I don't think it should be taken as like, oh, I don't, I think a lot of patients are either don't want to offend their doctor if they don't think that they're getting what they need. Does that make sense? Like we always have like really great relationships with our GYN oncology patients, and people are like, I'm not going to be offended. I think that's a great idea. If I can send you to somebody who knows a lot more than me and they can teach me something and then we can bring it on, I think that should be the way to go. So not being afraid of like getting outside opinions and kind of talking to your doctor who's managing your cancer about how that works with everything. I think it's really important as well. So
yeah, I love that you said that, to just ask for it. You know, you can
just
you
ask
can
for
ask.
it.
Yeah,
It's always going to give you good information, in my opinion.
Well, I can't thank you enough, both of you, for joining us today, this afternoon, this evening, depending on where everyone is. But we really, really appreciate this wonderful information. Please reach out to us if you have any other additional questions or needs. We're here for you, and just want to thank you again. And this will be posted on YouTube later, so if you want to come back to it and watch it again. So thank you, everyone,
Thank
for
you.
joining us. Thank you so, so much.